Okay, apologies, everyone. Thanks for your patience. All right, I hope that everyone's able to see our slide today. And this slide set is designed to present to you information around colon care 101. So what do we want you to know about the colon, as well as the rectum, colorectal cancer, and related health? These are my disclosures. To give you a brief overview of what we're going to discuss today, I'm going to give you an introduction to myself, my background, why I'm passionate on this topic, as well as introduce my colleague, Kristen Monks, who will be supporting our question and answer session. We're going to review the colon anatomy, as well as the colon's function, the general gastrointestinal system anatomy and function, just so you have concept how the colon is unique within the GI system. We'll, of course, review the gastrointestinal cancers, but focusing on colorectal cancer, the statistics, part of the epidemiology of colorectal cancer, prevention and screening, as well as treatment methodologies. And that will be followed by our Q&A. So a little bit about me. I have been a Carbondale resident for 4 years, and I am also a proud Valley View PA. I joined our team when I moved to Carbondale 4 years ago. My focus has been on general GI care and most recently on inflammatory bowel disease. So I do now a specialized clinic addressing patients with Crohn's disease as well as ulcerative colitis. I've been a PA for 11 years, but I've been involved in healthcare in some professional capacity for at least the past 17 years. And I am very proud of that. Clinical care, patient care, and medicine are my professional world and are very important to me personally as well. My background is that I have a biomedical engineering degree from Vanderbilt and a medical degree in PA studies, as well as clinical research from Wake Forest. And then personally, I enjoy all of the local activities: skiing, skinning, mountain biking, camping, and anything that involves me getting to spend time with my husband, my children, family, and friends. I am the proud mother to 2 kids locally who attend Crystal River Elementary School, Marlo and Everett, who you can see pictured here. And Kristen, I have the pleasure of working with and knowing. Kristen's been a resident in the Roaring Fork Valley for 3 years. She has been a PA in our department for 3 years as well. Her focus is general GI and hepatology, and she is the proud dog mom to Sebastian. She enjoys spending time locally with her family, as well as participating in hobbies that are quite interesting and fun: pottery, reading, as well as travel. So let's get started in talking about the colon. Many people will ask us in the clinic, what exactly is the colon versus the intestine? And so I want to start with nomenclature. The colon is the large intestine, and it includes all of the areas that you see in the picture here. It's also called the large bowel by many and in literature. Its main function is to transfer waste from the small intestine out of the body for elimination. When doing that, its main functions or responsibilities are to process and package stool by removing water and further breaking down stool content, which involves the bacteria that line the colon. And the process of elimination from the colon is done with packaged stool that is contained within the rectum being eliminated through defecation out of the end of the colon, which is called the anus. So pathology can happen at any points along the way in the system. And again, this is the large intestine, the large bowel, and the end of the gastrointestinal tract. We get asked all the time, how long is this really? It's about 5 feet or 150 centimeters in length. That's, of course, on average. More people will find with a colonoscopy that they have a longer colon. It may be noted on your report as tortuosity or long length or redundancy. And that's nothing to worry about, but it is just, we're on the farther side of the bell curve in terms of length, which is okay. There's the parts of the colon that are labeled here. And in order of how stool flows, we'll just go through the diagram. It's important to understand that you have the cecum, which is a pouch that is at the meeting with the small intestine. Stool then moves through the ascending upwards colon, that's on the right side of the body, across the transverse colon, down the descending colon, through the lower left quadrant of the abdomen, through the sigmoid, then to the rectum where it sits before elimination out of the anus. There's multiple levels of the colon wall, and we will go in detail on these levels when we talk about cancer development towards the end of our talk today. So other organs of the gastrointestinal system, I'm going to move through this pretty quickly since they're not the focus of our talk, but I do want to point out the whole GI system and its function. So the whole GI system's function is really digesting food and liquids for our body's use. And again, the colon is at the end of this and is mostly involved in transfer and elimination. Processing, digestion, absorption, it happens a little bit higher up and starts with the processes including the mouth, the pharynx, the esophagus, moving down to the stomach, the small intestine, and then the colon. There are accessory organs that are involved, including the salivary glands, the liver, the gallbladder, and of course the pancreas. This is a busy slide, and I'm just going to call out some key highlights here. So technically, gastrointestinal function starts at the time of when food enters the mouth with chewing and getting food prepared, for processing in the intestinal tract. And there is some digestion that occurs starting in the mouth with saliva, breaking down certain starches. Content then moves from the esophagus, through the esophagus into the lower esophageal sphincter, where it enters into the stomach. Stomach is where a majority of digestion happens with gastric acid, as well as enzymes that have been secreted into the stomach or that are secreted by the stomach. That content then moves into the small intestine, which is really the workhorse of digestion and absorption in our body. That is where you will hear of a lot of breakdowns of the nutrients that we take in. And then that content remains liquid as it passes into the colon. It's then processed by the colon, as I mentioned before. The other accessory organs that are very important to understand include the pancreas, which makes the digestive juices that help break down our food. And those are delivered into the small intestine through ducts. The liver also is a very important organ. Obviously, its role in the GI tract is that it does help make bile that helps digest our fats and some vitamins. Those bile ducts that are within the liver carry that content to the gallbladder for storage or into the small intestinal tract for use. And then the gallbladder being one of the main organs as well, it is an area where we have a lot of questions. And the gallbladder stores bile between meals, and eventually this bile does enter the small intestine through the bile ducts as well. So the outcome of this function is that your body gets what it needs from the food that we intake in order to help sustain our energy and our growth and our cellular repair. Of course, cancer occurs at any point in the gastrointestinal tract, and as your gastroenterology providers, we're constantly thinking about where this can occur, what the symptoms may look like, what the likelihood of the different cancers are, as well as what do we need to do for you, our patient. I wanted to list these here, although we're going to focus today on colorectal cancer. I did want you to have an idea of the relative rates of these cancers in relation to colorectal cancer, which is the most common gastrointestinal cancer. So colorectal cancer makes up 7.8% of cancer cases. And there is a lot of data that I'm going to present today on that. Esophageal cancer makes up about 1.1% of cancer cases. There's about a 0.5% lifetime risk for one to get that. The survival of esophageal cancer is notably lower at 21.7% versus some other cancers that we see. Gastric cancer is about 1.4% of cancer cases. And then the second most common gastrointestinal cancer is pancreatic cancer, which makes up about 3.3% of cancer cases. I encourage anyone who's interested to learn more about these statistics to check out resources through the National Cancer Institute. And now to our main topic for today, colorectal cancer. There are a few key statistics that are important to know regarding colorectal cancer that have been updated in recent years with the change that we've seen in trends with this disease. Colorectal cancer is used to describe cancer of the colon as well as cancer of the rectum. We'll call out today some specifics on those, but we'll talk about them as a group today. Colorectal cancer is the fourth most common cancer in the United States among men and women combined. And every year, approximately 150,000 people will be diagnosed with colorectal cancer. 50,000 people will die per year from the disease. Currently, there are about 1.5 million people living as colorectal cancer survivors in the United States. The majority of the population affected is in the older age range. The average age of diagnosis is 66, but as many of you have probably heard, and as we'll discuss today, there is an alarming increasing trend in incidence diagnosis rates in people that are underneath the age of 50. The lifetime risk for developing colorectal cancer is 1 in 24, and it's more accurately about 1 in 22 for men, so there is a male predominant risk here. Other statistics that I'd like for you to know and take away from our conversation today is that though this is the fourth most common cancer in the US, it is actually the third most common cancer worldwide. So this is a global disease. About 10% of cancer cases diagnosed worldwide are colon cancer or rectal cancer, and 8% of cancer cases in the US. So that's 8 out of 100 cancer cases will be colorectal cancer. It's the second most common cause of cancer deaths amongst men and women in the United States. And we'll discuss today why that may be. And very important to understand is that about 30% of those who are diagnosed have a family history of colorectal cancer or genetic syndrome that increases the risk related to colon or rectal cancer. I believe this slide does a really nice job with showing you all where colorectal cancer ranks along with the other cancers that we see most commonly in the United States. Those more common cancers include breast cancer, female breast cancer, prostate cancer in men, and lung and bronchus cancer. Colorectal cancer incidence is followed by melanoma in terms of the next most common cancer diagnosis that we see. And I would like to call out the other gastrointestinal cancer on this list, pancreatic cancer, and you can see that the number of deaths due to pancreatic cancer due to the poor survival outcomes is just beneath that of colorectal cancer annually at 50,000. As we mentioned, the age at diagnosis for most people is older, and this bar graph demonstrates that very nicely. So though the incidence, the diagnosis rate is rising in those who are underneath the age of 50, we still see the majority of diagnoses come up to age 66 or above. And this slide, I think, is very important for helping you understand where we are diagnosing this in terms of the extent of the disease, the stage of the disease at the time of diagnosis, and what that correlates to in terms of outcomes. So one point of optimism that I want everyone to take away from this talk is that when colorectal cancer is caught in a localized stage, stage 1 through 3, it is very often something that has a strong survival outcome. So a 90% 5-year survival is really great in terms of a cancer outcome, meaning that 5 years out of their diagnosis, 90% of those with the colorectal cancer diagnosis would still be alive versus those who do not have that cancer diagnosis. However, the percent of cases that are diagnosed at this localized stage with this great outcome is only 35%. And so we are still seeing significant disease as well as death related to colorectal cancer because of this. This is one area where we can turn the needle with screening, which we're going to talk about today. So I want to emphasize here with this slide that early diagnosis does result in improved survival and less late effects from more aggressive treatment courses, which we'll discuss. And so screening is important. Some risk factors to understand and to make sure that you consider when you are considering your care, your preventative care, lifestyle changes, as well as your screening habits. As we discussed earlier, it is more predominant in men, and there is a hypothesis behind that. So the 33% higher incidence rate in men may be due to some risk factors that we'll discuss further, including excess body weight or the consumption more often in men of processed meat. And there's also the age predominance that we've reviewed. Versus Caucasian white Americans, we see a much higher incidence diagnosis rate in those with Alaska Native, American Indian, as well as Black race ethnicity. There's a 2 to 4 times increased risk over one's lifetime if they have a first-degree family history of colon cancer. And there are other cancer risks related to family history, which include family history of colon polyps. So when you're talking to family members after a colonoscopy, particularly first-degree family members, it's important for you to ask if they're comfortable with sharing if they had any polyps and if they were advised to screen more regularly. That would be an indication for you that you're eligible as well. There are some genetic syndromes, and if this applies to you, then you should be in regular contact with your healthcare provider regarding screening. Lynch syndrome and familial adenomatous polyposis, I abbreviated here, are 2 of the most common ones that we see. And you have a much higher risk over the lifetime of developing colorectal cancer, and you should be in a regular screening program, as well as established with someone who's guided you on other cancer genetic risk screening behavior. Having an underlying history of inflammatory bowel disease, which includes ulcerative colitis and Crohn's, does also increase your risk for colorectal cancer. And then here's some modifiable and important lifestyle risk factors to know. Those with a history of type 2 diabetes, particularly uncontrolled, those with a diet that's high in red and processed meat, or low in calcium, or low in fiber are at risk. Risk factors such as smoking, as well as moderate to heavy alcohol intake, are related, as well as limited activity, inner exercise, and obesity or overweight. I want to make sure that everyone walks away with understanding the symptoms of colorectal cancer, and my bottom line on this is seek care. If you have the symptoms, they could be related to many of the other types of pathologies that we see in gastroenterology. However, most important is for us to work together to ensure that we are thinking through the likelihood of colorectal cancer and that we are ruling that out. So that would include symptoms such as changes in bowel habits, like ongoing diarrhea, constipation, or an alternating pattern, red blood or black color, or other changes that are persistent in the appearance of your stool or rectal bleeding, a regular feeling of not being able to empty your bowels well, or a feeling of incomplete emptying when you go should give you, room to observe, and then if that continues, to notify your provider. Abdominal pain that is persistent and getting more severe, that could include cramping, unintentional weight loss, fatigue, and weakness, as well as the diagnosis of iron deficiency anemia should be discussed. So on to the topic of what's going on with the increasing disease rate of colorectal cancer in the young adult population. This, in our gastroenterology and cancer disease world, is called young onset colorectal cancer, which refers to cases that are diagnosed under the age of 50. Colorectal cancer is the #1 cause of cancer death in men in this age group, and is the #2 cause of cancer death in women in this age group. These rates are globally increasing, so it is not a US specific trend. And we'll talk about why that's important in a future slide. And I do want everyone to know that this trend has been observed since it's observed for those who were born after 1994. So if you're born after 1994, your overall lifetime risk is increased by about 51% versus those born previously. And the risk is higher for rectal cancer versus colon. So 4 times increased risk for rectal versus 2 times increased risk for colon cancer. Due to this trend, the Multi-Society Task Force that sets our screening guidelines, as well as the American Cancer Society and all of the different medical societies, decided to move the screening age from 50 with colonoscopy or other method, where it's been for many years, to 45. And unfortunately, what we've seen since that change was enacted is that only 20% of those now eligible for screening are screening. So I encourage anyone in this age range to help us move this statistic up. It will have a dramatic improvement with diagnosis and lives saved. So we should be screening in this age, but it's also important to note that about half of the cases of this young onset colorectal cancer are in the age below the screening age, so age under 45. This could be due to those with family history, and if you have family history, you should be screening earlier, so that's something to discuss with your provider. It could also be due to some lifestyle factors, as well as the healthcare behaviors in this younger population, which we'll discuss. 10 to 20% of these early onset colorectal cancers are related to inherited factors, but it's thought that environmental risk is likely playing a role based on the fact that this is a generational trend. Some hypotheses and research is ongoing regarding the influence and the interaction and interplay between our diet, our gut microbiome, and systemic and chronic inflammation. And then we are concerned that there are some potential environmental influences such as pollutants or chemicals that we've been exposed to in this generational trend that we've seen. So those born after 1994 versus before. There are the modifiable lifestyle factors, and I cannot emphasize enough how much these play a role in colorectal cancer. Diets that are high in processed meat, red meat, and meat fat, as well as diets that are low in fruits, vegetables, and calcium, are a very poor and portend significant risk for colorectal cancer. And about half the cases that we see are going to be in people who are overweight, and 70% of the cases that we see are going to be in those who qualify as obese. So there is a strong understanding that inactivity, low physical activity, and exercise are linked with an increased risk. And there's a really interesting paper published that showed a direct link between more TV time. And that was a very small study, but I thought that it was interesting. Further statistics on this point and in response to why we may be seeing this is that some results from a survey of those who've been diagnosed for colorectal cancer in this young adult population told us that they were 54% were initially misdiagnosed, 43% thinking that they might have had hemorrhoids or hemorrhoids along with something else like IBS. And so if you are struggling with the symptoms that we've talked about, I do want you to know you need to seek care. I'm going to go back to a previous slide to show you in surveyed populations of those who have had young onset colorectal cancer diagnosed, symptoms of diarrhea, rectal bleeding, abdominal pain, and iron deficiency stood out as the 4 symptoms that were most associated with the diagnosis happening within 2 months to 3 years. So if you've experienced those symptoms, please discuss them with a healthcare provider, or if any family members are mentioning these symptoms, encourage them to seek care as well. Patients who are young, so ages 19 to 39, are more likely to report that they've been dismissed based on the discussion of their symptoms. So keep going back and keep plugging along if you're getting concerned. 36% of patients may see 3 or more providers before getting a diagnosis of colorectal cancer in this age group. So what does this mean? This means that we're going to see delayed diagnoses, more advanced disease progression by the time they're diagnosed, which portends for worse outcomes. There is some influence of stigma involving colonoscopy and stigma involving the screening methodologies available that are not colonoscopy, including stool testing. And then there's also the population trend. This is the working, predominantly working age group. So many people are busy with work, don't take time off from work to do preventative care, and therefore may be less engaged in screening and more likely to ignore or put off the signs. The hypothesis involving the gut microbiome, as well as what we eat, so things within our food, and how that influences the gut microbiome and systemic inflammation, are really interesting. We're not going to go into too much detail here due to time, but about half of the cases in young adults are in people who have had a chronic disease, which could influence this picture of chronic inflammation. And that chronic disease certainly may involve the altered gut microbiome. Now on to a very important topic that's close to us in gastroenterology of colorectal cancer screening. This diagram really nicely outlines that if you have a first-degree family history of colorectal cancer, then you need to be screening earlier. You should be starting at age 40 or getting a colonoscopy for your screening 10 years before the diagnosis of the youngest age first-degree relative. So if you've had a family member first degree who was diagnosed at 30, you need to start screening at 20 with a colonoscopy. Colonoscopy is the recommended mechanism for those with a family history for screening. For those who are at normal risk, or what we call average risk, you have other considerations, and you should start at age 45 now. And those include colonoscopy or a flexible sigmoidoscopy and stool-based testing, such as a FIT test, a Cologuard test. We'll talk more about those later on, but the stool-based testing is certainly an option for those who are not ready to start proceeding with colonoscopy. So for average risk, starting at 45, screening continues through age 75 routinely, and then set ages 76 to 85, it involves a discussion with your primary care provider or other trusted providers, see if you're appropriate to continue screening and if you would like to, and if you have risk factors that indicate you should. Screening beyond age 85 is not routinely recommended due to risk of the procedure and risks related to diagnosis incidence of comorbidities at that age. However, this can certainly be pursued by patient and provider preference based on your review of your health risk as well as your health status and your colorectal cancer risk. Those who are at high risk should be screening again 10 years before the age of the earliest first degree relatives diagnosis or at age 40, whichever is earlier. And then your screening interval with family history will be more frequent than those who do not have a family history. The stool test recommendations for a FIT test, which is a fecal immunochemical test, are to be done annually. The Cologuard test should be done every 3 years, as long as it's normal. Of course, for abnormal results, we're recommending differently. And then a colonoscopy, if normal, is done every 10 years, but other surveillance timeframes are recommended if you have polyps. What is a colonoscopy? I think most of you are probably familiar, but a colonoscopy is used for colorectal cancer screening as well as for diagnostic gastroenterology evaluations for symptoms such as those that I mentioned before: pain, bleeding, change in bowel patterns, or assessment for anemia. The colonoscopy allows us to go into the colon with an endoscope, a colonoscope, and directly survey the inside of the colon and remove any polyps. So colonoscopy stands out as that it's preventative. It allows for polyp removal, which will prevent the progression from a polyp into a cancer. And polyps are actually how most cancers start out. These are just an overgrowth of cells. They are abnormal but benign, but they do have malignant transformation potential if they're longer in place or if they grow into a large size. That malignant transformation rate is about 5 to 10% of adenomas, these types of polyps that could turn into a tumor. Some will have higher risk than that, than others, a term that we will explain to you or other gastroenterology provider would explain to you with your pathology report. We know that polyps that are on the right side of the colon, or polyps found in those who are Black Americans, are more likely to portend higher risk for overall colorectal cancer or future polyp diagnoses. Here's a picture of colon polyps and a picture of what it looks like when we're inside of the colon with the colonoscope. There are these little overgrowths of cells that we're able to remove. And if we find these, your endoscopist is going to set the final recommendation for when to come back for your next colonoscopy. But this slide demonstrates that if you've had a high quality colonoscopy, then if you had polyps removed, these are what you can expect in terms of when to come back, these recommendations. So for a few polyps or small polyps that do not have the highest risk features and are less than a centimeter, you're going to be coming back in 7 to 10 to 5 years. Higher risk or larger ones, it's going to be sooner. The stool testing options I want to highlight can be available to you at any time online or through your provider. So talk with your provider about stool testing if you're not interested or not high risk to proceed with colonoscopy, although colonoscopy is the only screening method that's preventative, and I emphasize colonoscopy is the best screening method, but the best screening method is the one that will be completed. So please do consider these options. You could buy a FIT test online. You can request a Cologuard online, which will involve a virtual consultation. You can also request a Cologuard test through your primary care provider. I'm excited to share a policy update that came out in January of 2023 through an omnibus package from the Senate. And that is that after a positive screening test with a FIT test or a Cologuard test or a CT version of a colonoscopy, you can have a colonoscopy that follows that is still part of your insurance plan coverage for screening. So it's considered screening, not diagnostic, and this is a change from years prior, which really affected how much the out-of-pocket cost would be for a follow-up colonoscopy after a non-invasive screening test. You may have heard about a test that's on the horizon, or test plural. There have been a few of them that have tried to reach market. So one of the main barriers that I mentioned is stool and colonoscopy and the stigma related to that in certain population groups. So this blood test may help us capture about 1/3 of people who are eligible for screening, but who are not screening. And this blood test tests for circulating DNA. It has a little bit lower sensitivity than what we see with colonoscopy, as well as what we see with other testing methods, but it does have high enough sensitivity to still be approved by the FDA for screening. And we are just waiting FDA approval and CMS approval before this can be offered. It is something that you can purchase online right now, but it's not yet covered by insurance plans. But I am hopeful that this is going to be another tool in our toolkit to encourage people towards screening, particularly those who are declining to participate in stool testing or colonoscopy. And I want to highlight this is not a preventative test, and it should only be offered to those who decline the other methods of screening. And as I've said before, the most effective screening test is the test that is completed. And if we are screening more people, it might be possible to prevent 73% of colorectal cancer deaths with earlier detection. And on that note, the note of prevention is so important because we can do a lot. 55% of colorectal cases are attributed to modifiable risk factors, which means we can reduce our risk with lifestyle change. I want to highlight the most effective lifestyle changes would include diet, activity, and risky behavior change, so alcohol use as well as tobacco use. Changing your level of activity alone from sedentary to being active on a regular basis will reduce your risk by 25%. So some goals with exercise just include exercise that can be light to moderate or vigorous, but at least 10 to 15 minutes a day of something light. We do encourage abdominal stretching and things that help strengthen the digestive tract from a standpoint. It's been shown in literature to improve general GI wellness. And then other healthy colon habits include, of course, screening, and then reducing your overall stress levels, listening to your body and seeking care when you can, as well as making a plan to quit smoking, and making a plan to address being overweight or obese if that applies. We also encourage people to go to the bathroom when you have the urge. There's some early data on the need for people to have good bowel habits, and that might improve risk. From a preventative standpoint, there's a lot that can be done on the diet front. So obviously we've talked about the red meat and the processed meat, limiting that in your diet, controlling the dietary factors that will increase your risk for obesity, such as fried foods and excess sugar, starchy fruits and vegetables, as well as alcohol. There is a preventative effect of calcium in the diet. So the recommendations are for people, especially at higher risk, to drink about 3 to 4 8-ounce glasses of low-fat or fat-free milk daily. And I do want to say that that would be as tolerated. And if you have a different calcium choice, that should also be appropriate to discuss that with your doctor. We also recommend increasing your fiber intake, particularly whole grains, fruits, and vegetables. And many vegetable sources will have a lot of calcium, such as kale, spinach, collard greens. And for all bowel reasons, including colorectal cancer risk, please drink at least 8 glasses of water a day for a healthy colon. I found some interesting research and preparation on whole grains and gluten and colorectal cancer. And given that many people in the young adult population are following a gluten-free lifestyle, investigators sought to look and see if that may relate to the increased risk. It did not, but what was found is that in this very large population that is currently under study, over 50,000 men and 62,000 women, more whole grains was associated with decreased risk of colorectal cancer in men, but not in women. And eating more gluten may increase the risk of colon cancer in the first and middle areas of the colon, but a gluten-free diet was not found to be associated with any risk. Eating refined grains, white bread, pasta, white rice did not associate with increased risk of colorectal cancer, but I will advise that oftentimes those are not in the preventative category of foods, and you could choose from a preventative whole grain. Moving on for the end of our conversation to colorectal cancer treatment and what happens after diagnosis, I want to put a spotlight on our incredible team at Valley View's Callaway Young Cancer Center. I have the privilege to work with all of the physicians and advanced practice providers on that team, and I cannot speak highly of each of them enough. Dr. Donovan, Dr. Rossi, and Dr. Kopp are pictured here. That they have some excellent APPs on their team, including Kristen Johnston, Megan Crawford, Kelly O'Brien, as well as P. Matt Stinson. And so if you or friends are seeking advice from a cancer care team, please reach out to them. What to expect with the workup related to colon and rectal cancer includes our pathology report or other pathology report from wherever the colonoscopy was obtained. And that is going to include information regarding the tumor type, cell type, sometimes information that will involve extent or level of activity of the disease, as well as tumor testing for these specific elements that will guide treatment. So we've made a lot of advances in treatment that is specialized based on these factors. You also may undergo genetic testing for some of the cancer risk syndromes, and that's also helpful for people to know to be able to guide their family. There are important biomarkers to test for, especially with metastatic or widespread disease that spread outside of the area of the colon to the rest of the body, or including most likely the liver or the lung. And then typical blood work that we need at diagnosis in order to understand more about how you're doing overall. Imaging to get more of an idea on the extent and the spread of the diagnosis. And then for those who are still in the family planning stage, it's important to consider that there's a lot of options now with fertility and family planning that need to happen before the time of treatment. This image shows how a cancer grows inside the colon or the rectum. And as you can see, you've got a little polypoid growth on the far end, very small, that over time invades through the wall. And this can be classified as stage 0 through stage 4. Stage 0 means that the cells are very, very localized to the innermost layer of the colon wall. Stage 1 means that the cancer has grown into the second or third layer of the wall. Stage 2, that the cancer has grown to the extent of the colon wall or just beyond. And stage 4 means that the cancer is involving local lymph nodes. Stage 3, local lymph nodes or tumor deposits in the fat right around the colon or the rectum. And stage 4, that the extent has spread farther out through the rest of the body, particularly colon and rectal cancer will go to the liver and the lung. I want to quickly move through some of the surgeries that are part of the treatment profile for colon cancer. So colon cancer, when caught early, can be removed with surgery. You excise the part of the colon that is affected by the disease, and then the neighboring connective tissue as well as the intestinal tissue are reattached. So that is an option for many people when the diagnosis is found in the localized stage. And this surgical process does involve removing lymph nodes and assessing those for spread of disease. For a multitude of reasons, either due to location or extent of the disease, it may be necessary to do a temporary colostomy with the colectomy, which is where the end of the colon is attached to the abdominal wall and you have a colostomy bag. This is usually reversible for many people diagnosed with colon cancer, when you can reattach that colon later on after it's safe and appropriate medically to do so. Systemic therapy used now for colon cancer treatment does include chemotherapy as well as immunotherapy. We don't have time today to go into details of this, but I wanted to show on this slide that those tumor markers that are identified at the time of diagnosis are actually used to help inform treatment options, such as whether or not chemotherapy or immunotherapy is appropriate and at what stage. So for instance, those who have stage 2 treatment or stage 2 disease will have chemotherapy after the colectomy if they have higher risk, and chemotherapy is recommended for all stage 3. And chemotherapy agents are listed here for those of you that are familiar: capecitabine, 5-FU, leucovorin, Capox, and Folfox. We join back in on your care as your gastroenterology team after colon cancer has been treated and we're in the surveillance stage. And so we'll work with the cancer teams to make sure that we are delivering on timeliness and regular colonoscopies to ensure that there's been no evidence of local recurrence, a recurrence where the tumor previously was. And then we will continue screening you when you're outside of surveillance, which is beyond 5 years after the time of treatment's over. There are certainly cases that are diagnosed more advanced, stage 4, and there are some outstanding options now with metastatic colon cancer treatment. And I want to highlight a few of these here. Biomarkers are definitely important for planning of this, so your oncology team would take care of that. And the Callaway Young Cancer Team does a great job with that. They have a tumor board that meets, reviews all of this information, and has multidisciplinary input on what the plan will be. So the plan could include some of the newer modalities of image-guided therapy, and that would include delivering tumor ablative techniques directly to the tumors wherever they are in the body, particularly the liver or the lung. And this can occur with thermal ablation or some very unique image-guided surgical techniques, as well as radioembolization, delivering radiation therapy to the site, or chemoembolization, chemotherapy to the site. And external beam radiation therapy is very advanced now, and we offer that to many patients here at the Callaway Young Cancer Center in terms of treatment for specific tumors in the body using a therapy called SBRT, or stereotactic body radiation therapy, that allows for very precise treatment just to the tumor tissue over a few short sessions, maybe 5, maybe 3. I'll move on now to briefly touch on rectal cancer because it is treated differently. And there are a few very nuanced surgical approaches, as well as chemotherapy and radiation regimens. Surgery is required for some, but there are now rectal cancer treatment protocols that are not requiring surgery. So what I've shown here is a low anterior resection where the rectum is removed and then the colon and the anus are rejoined. There is the ability to do an abdominal perineal resection, APR, which is similar, but the end result is the colostomy, as you're going to create an exit through the abdominal wall. Rectal cancer systemic therapy agents are similar, but the timing of delivery for these is different. Oftentimes these are given up front before surgery, and they're oftentimes given in combination with radiation therapy. And we jump back in for rectal cancer survivors as well to start with regular colonoscopies or flexible sigmoidoscopy exam, focusing on the rectum. We do that regularly through the first 5 years out from diagnosis. And then we carry along with you long-term to make sure that you are getting lifelong screening as well as surveillance. I wanted to mention that we do offer a few other procedures at Valley View here. And these procedures are not directly related to colorectal cancer care, but I do want to highlight them for those of you that may be unfamiliar. So we offer colonoscopies and flexible sigmoidoscopies, an upper endoscopy, which is also called an EGD, or esophagogastroduodenoscopy, which looks at the upper GI tract. So extending from esophagus, stomach to the first portion of the small intestine, including the duodenum. We are now very grateful to be able to offer endoscopic ultrasound, which is an advanced procedure that's done by our medical director, Dr. Magdi, and that is going in through the upper endoscopy approach, but using an ultrasound probe to look at neighboring structures that are not contained within the gastrointestinal system, but are related. This is also very important in the cancer staging process for some, particularly with metastatic disease, are concerned for that. We offer therapeutic procedures, including ERCPs and GPOEMs and POEMs, which I won't describe today, but if they come up for you, those are procedures that we do here. Including some references that I recommend anyone who's interested can look further into, particularly the websites where I pulled a majority of our statistics: the National Cancer Institute, the American Cancer Society, the National Comprehensive Cancer Network, as well as the Colorectal Cancer Alliance. Okay, and now for our Q&A. Thank you so much for your time today. I know that we've covered a lot and I had to speak quickly through some of it, but it's been my pleasure to be able to talk to you on this very important topic. Okay, so I have my colleague Kristen, who's going to help me with some Q&A, and we'll do our best to answer these. And if we're not, we'll try to follow up with you afterwards.
All right, just a couple. I have heard that having UC or IBD for 10 years increases the risk of colon cancer. Does this mean active ulcerative colitis during the course of the 10 years, or can some of that 10 years be inactive without medication treatment?
That's such a good question. And I address this a lot in our clinic. So inflammatory bowel disease overall increases your risk for colorectal cancer in the area where disease has been active. It is an increased risk also with areas where you've had more severe disease, and the risk is reduced with controlling the disease. So with that said, it is very hard to give statistics on how at risk one is or how much your risk is lowered, because the level of control of the disease has changed over one's lifetime since their diagnosis. And that is why the screening recommendations kick up the longer that you've had the diagnosis. So if you were 8 or more years outside of your diagnosis, or if you were diagnosed initially with more extensive disease involving a majority, greater than a third of the colon, you would be recommended to have regular colorectal cancer surveillance and screening with an annual or farthest out every 2 years colonoscopy. And that's due to, again, extent of disease, severity of disease, and increased risk with those factors. Does that address?
I think so.
Okay.
And then do we know why there's increased risk with some of the risk factors as far as the red meats or obesity? Do we know a specific link with that?
Oh, thank you so much for that question. It's really important because as we modify our lifestyle, we kind of want to understand why, and maybe this meat's okay. So there's some great studies that are done on the lifestyle risk factor study that I mentioned that has the over 50,000 men and over 60,000 women enrolled. And what the studies have shown is in that study, as well as biochemical studies, is that it is most likely the heme iron in the red meat that portends the risk with red meat. So the protein of the animal, aka red meat, and the type of heme iron with that in that muscle. Now, there is the possibility that increased calcium in the diet can be a neutralizing factor for that food risk. With processed meats, it is thought to be the process of nitrite curing. So nitrite curing increases the release of toxic chemicals, and that is ingested and then impacts the colon wall and portends the risk there. So with those, you would want to make sure, if you are still going to buy processed meats, that you look for the ones that are nitrite free or did not involve nitrite curing, and perhaps you select a processed meat that is not a red meat, and that could be better. You can reduce your risk with cooking also, because there is risk with direct contact with a flame with the meat. So if the meat is cooked over a flame or has direct contact, it releases these specific carcinogenous chemicals, and those are then ingested, increasing your tumor toxicity contact in the colon with that food. So if you cooked your meat in a aluminum foil wrapper, that's actually recommended in large studies, you are likely to have less risk. And then in terms of diabetes, obesity, overweight, and fat intake, there are many hypotheses on this as well. This is not well determined, but we know that because of the way that fat works in the body to increase circulating levels of insulin, and with the fact that you have that process occurring in diabetes, that is in its own a carcinogenic process within the body, or promotes oncogenesis, which is tumor promoting activity. So you could shave fat off of the meat, and that is one preventative way. And then in terms of what you're eating and diabetes control, so controlling your diabetes and reducing your overall weight helps to mitigate that risk.
Perfect. I think that's all we have time for.
Okay.
But thank you so much.
Absolutely. Well, it's been a pleasure. Thank you all for attending. I have a quick announcement to make before you sign off. We'd love to hear your feedback on today's presentation. So if you have time to fill out the quick survey, it will be available right after this webinar is ended. Also, you'll receive an email with a recorded webinar within the next 24 hours. And we do have an upcoming Valley View University we'd love for all of you interested to attend on April 3rd at 6 p.m. And it's going to focus on advancements in knee replacement with one of our orthopedic surgeons at Valley View and joint specialist, Dr. Daniel O'Connor. So to register for that and any of our other webinars, please do go to vvh.org/VVU. And if you have a topic suggestion for us, please email us at vvu@vvh.org or drop it in the comments or on the feedback form. And stay tuned. We look forward to doing this more.